Please note, this video is a demonstration of the intubation of the COVID or suspected COVID patient. The intubator demonstrated is wearing PPE. The assistants, however, are not. Please remember all members of the intubation team are to be in full prescribed PPE at all times. Please be aware that your institute may have strict criteria regarding patient selection or exclusion for intubation. Please adhere to local criteria as these may differ between institutes. Indications may also include increasing FiO2 requirements, clinically worsening distress, predicted deterioration, or failure of non-invasive oxygen supplementation. Preparation for intubation includes preparing your team in full PPE. This team should consist of the least number of people necessary. 2 to 3 members may be needed. If 3 are needed, have the third safely remove themselves from the procedure as soon as possible. Further preparation includes equipment, drugs, and ventilator. Prepare all equipment prior to intubation. An equipment checklist will be provided. Equipment needed is as follows: video laryngoscope, suction, endotracheal tube preloaded with a syringe for inflation of bulb and an introducer. Preset the ventilator and attach to elephant tubing and filter. Trachea tape is needed, as well as a rescue airway which will consist of a laryngeal mask airway and a bougie. COVID airway packs should be pre-packed and include items on the checklist. Be sure to have rescue drugs ready, including push-dose adrenaline and infusion prior to intubation. Preparation of the intubation box: tape plastic over the arm ports and make a slit in the plastic for access. Tape plastic drape over the distal large opening in order to cover the entire patient. Preset the ventilator to initial rescue settings in case of a failed airway. An additional video will be available to demonstrate the approach to the failed COVID airway. Rescue settings include SIMV mode, respiratory rate of 15, tidal volume of 8 mL per kilogram of ideal body weight, FiO2 of 1, PEEP of 5, which is to be cautiously titrated according to the patient's response, a flow rate of 60 to 80 liters per minute, and an IE ratio of 1 to 2. Prepared drugs for rapid sequence induction. Full PPE is to be worn by the entire team involved in the intubation of these patients. Pre-oxygenate the patient using a non-rebreather mask for 3 minutes at tidal ventilations of 6 liters per minute. Administer induction agent followed by paralytic. Once the patient is asleep, lie the patient flat and have the team place all equipment next to the patient in the following configuration. Notice that a bag valve mask is not placed in the box, but must be kept available in case it is needed. Have the staff place the box over the patient by bringing it from the foot of the bed to allow the plastic drape to cover the entire patient. Tuck the plastic drape underneath the patient's shoulders and box edge, allowing some slack over the opening. Intubate the patient using the video laryngoscope. Inflate the bulb and immediately attach the ventilator and press start. Have an assistant hold the ET tube from the clean surface of the plastic drape. Remember, full PPE is to be worn. Confirm placement visually and using end-tidal CO2. Consider placing a nasogastric tube at this time. After successful intubation, change the ventilator settings as follow: SIMV mode, respiratory rate of 18, tidal volume of 6 mL per kilogram of ideal body weight, FiO2 of 1, a PEEP of 5, which is rapidly to be titrated according to the patient's hemodynamics, and an IE ratio of 1 to 2. Please see the accompanying PDF for further information.